What is the role of minimally invasive surgery in locally advanced gastric cancer? In the initial slides, I said that the challenge in locally advanced gastric cancer is more towards open surgery and less minimally invasive surgery. Of course, in expert centers that can be done. So this class 1 trial studied over 1,000 patients, laparoscopic versus the open distal gastric for D2 lymph node dissection. The 3-year survival said that it was comparable in both the laparoscopic and open group, and 3-year overall survival also was the same. So it amounts to say that even the class 02 trial also has told us that fewer early complications were noticed with the laparoscopy group, and also the 3-year relapse-free survival was better. So at experience centers, a minimal access approach can be still done for a locally advanced gastric cancer, even it amounts to D2 plus or D3 lymphadenectomy, and also if it involves a multivisceral resection. This is the message that we should carry on. So this also says the same. So now the robotic surgery, I know in the inaugural address they told me that I should not be more persisting, but there is good evidence that robotic surgery in locally advanced gastric cancer has some advantages over the laparoscopic group vis-a-vis the open group. So it gives us less blood loss, we have better resectional margins, there are more lymph node harvest as shown in the previous presentation also, and also early recovery, shorter hospital stay, these all add us to the advantages that a robotic surgery can give in local advanced gastric cancer. In the early gastric cancer or borderline ones, the laparoscopy and robotic have got similar results, but in local advanced gastric cancer surgery, robotic has definitely better advantages over the laparoscopic trial. So there's one ongoing trial, the results will be expected soon, which will directly compare the robotic or the laparoscopic surgery in gastric cancer. Current recommendations, what we should remember, NCCN tells us it can be considered in select cases. It is contraindicated in T4B and N2 bulky nodal disease, but we have seen the recent studies which say that even in local advanced involving multivisceral resections, robotic surgery can be considered. The Japanese guidelines, they do not give any clear recommendation for laparoscopy in locally advanced cancers, but robotic is not recommended in the Japanese studies. So omentectomy removal is recommended in T3 or deeper lesions. Bursectomy there's no survival benefit, but we also know that if there's a posterior wall lesion, T3 plus lesion, bursectomy addition would probably give a benefit, though not demonstrated as much in the studies. So multivisceral resections, a quick word about them. Multivisceral resections for local advanced gastric cancer, definitely there is a role. The improvement in the R0 resection is enormous. The spleen, colon and pancreas are the most frequently resected ones with the least morbidity. Pancreas, addition of pancreatectomy will add some morbidity, but colon and spleen addition of these two organ resections is not going to add so much of morbidity. But if you can see, the survival rate of 1, 3 and 5 year is slightly better in the absence of a local additional organ resections. So the NCCN recommends additional organ resections whenever required for improved outcomes. The Japanese also recommend additional organ resections for in situations for local advanced gastric cancer. So this we will leave this. These are the guidelines which I just said. What we have to remember here is that minimally invasive approaches can be considered in select cases at expert centers, and this is about the HIPEC and PIPAC, which are still under trials. There is no recommendation to use HIPEC or PIPAC even in local advanced gastric cancer. The guidelines only restrict us till the diagnostic laparoscopy and peritoneal cytology for staging, not as part of treatment. So I think we have to remember these things. Thank you for your kind attention.